Hi everyone, welcome to researchmd.com. Another great presentation today. So we're going to look at the treatment. How do you treat cardiogenic shock? Again, my name is Pramil. I'm a program director, internal medicine residency, transitional residency. I teach medical students and residents on a long term for a very long time, and I'm also an assistant director of medicine at two major medical schools. Let's look at it. So when you look at cardiogenic shock, let's look at some numbers we need to know. Blood pressure less than 90. Reduced cardiac index, what? Less than 2.2, and in presence of elevated pulmonary wedge pressure greater than 18 millimeter of mercury. Okay, so cardiac output is decreased, PCW, pulmonary capillary wedge pressure is increased, and your CVP is increased, blood pressure low, and systemic vascular resistance is increased. Okay. And then immediate treatment. What's the first thing you have to do? Make sure like saturation is like give oxygen to make sure. I mean, even especially the people with less than 90% oxygen saturation, they may have to intubate and mechanical ventilation to be started. And then 100 to 200 ml of fluid boluses may be required to optimize the left ventricular pressure in patient with a developing cardiogenic shock with the pulmonary capillary wedge pressure less than 50 millimeter. And then avoid fluids if the frank pulmonary edema is present, or if the pulmonary capillary wedge pressure is greater than 18 millimeter of Hg. Okay, and the other immediate treatment is like, again, IV inotropic support is the most important thing for systemic perfusion. So what are the one we can use? We can use norepinephrine, doses given below, and dopamine and dobutamine. Those are the three things we can do: norepinephrine, dopamine, and dobutamine. Okay, and let's say some of the things like what else we can do in right ventricular infarction. Dopamine is preferred, okay, and the vasopressin is the next story. Aortic stenosis, phenylephrine is preferred, also vasopressin. Dobutamine is titrated, guided by the echocardiography or pulmonary capillary wedge pressure catheter. Aortic regurgitation, you can use dopamine or temporary pacing. Mitral stenosis, you can phenylephrine or vasopressin. Esmolol or amiodarone, and mitral regurgitation, you can norepinephrine or dopamine. Okay, so the other immediate treatment for like STEMI, consider mechanical cardiovascular support in the who do not quickly stabilize, right? You can use the intra-aortic balloon pump, Impella, tandem heart, and ECMO. Now, immediate treatment, also consider emergency revascularization. If medications, other procedure don't work, percutaneous coronary intervention, coronary artery bypass graft, and then emergent surgery, like situations like when there's like mitral regurgitation due to papillary muscle rupture, right? Ventricular septal rupture after STEMI, ventricular free wall rupture following STEMI. Those conditions are the main thing. You have to call the surgeon and get to the surgery like right away. Now, when you look at the patient with a treatment of persistent cardiogenic shock, consider again inotropic support like a bridge therapy while awaiting for the mechanical or circulatory support or cardiac transplantation. Consider left ventricular assist device, LVAD, for circulatory until you get the patient more stable. And then cardiac transplantation also be the last option. And then consult palliative care, and then long-term continuous IV inotropic support, or in a palliative care setting is also important. Thank you so much for watching our presentation. We'll be back with another presentation soon. Please subscribe to our channel.